All right, so this is just too cool not to share. I wanted to share an update on this case that I've talked about already a couple times. So this patient we talked about presented with these papillonecrotic lesions on the trunk and extremities, really complicated past medical history, including an indolent leukemia in the blood that was occurring, as well as cryoglobulinemia of unclear significance. Had been on multiple rounds of immunosuppression for the leukemia with lack of response. Presented to me with these papillonecrotic lesions. We biopsied, it showed pseudoepitheliomatous hyperplasia with neutrophils, which entertain a differential of infection, halogenodermas, and pemphigus vegetans, among others. Those have all been rolled out respectively with PCR, serologies, and serologies. So it really is not favored to be any of those diagnoses. And so at that point, the underlying leukemia and the skin hadn't really been responding to many of the therapies. So the decision was made to go ahead and just stop the treatment, which was riloxitinib, a JAK1 and 2 inhibitor for the underlying inflammatory subtype of a leukemia, and see how he did. And what you'll see here on the left is the clinical appearance just a few weeks ago when I saw the patient, and then here on the right was just a couple days ago. So just within a few weeks, the lesions have markedly improved. You see shedding of the eschar, the ulcers kind of filling in, going from more full thickness ulcerations to erosion. So this patient has gotten better just on decreased immunosuppression. So what's the final diagnosis here? I don't really know. The theory I have is that it's some type of immunomodulatory or dysregulated T cell proliferation or T cell process. Things that support that are the same clone that was known to be responsible for the T cell leukemia was found within the skin. The patient responded with decreased immunosuppression. So that probably lifted or kind of pushed the immune system back to a more regulated state, which kind of disallowed or discouraged those T cells to hang out in the skin. And all the other competing etiologies like infection, halogenoderma, autoimmune blistering disease, etc., were thoroughly ruled out with universal PCR, biopsy results, serologies, things like that. So this is a nice example of a few things. One, sometimes the best thing to do is just nothing, stop medicines, reevaluate and see where you're at. Two, this is a good example of how healing of necrotic wounds looks like. So it goes from a full thickness eschar to just superficial erosions uh, here. And three, sometimes we don't always have a great answer for what a diagnosis is. So it's hard to say what something is, but we can say what something isn't. And so we can rule out competing etiologies and in the process do well for our patient.